Friends, in this series of ECG basics, today I will talk about the QRS interval. First is the disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. The QRS interval, it starts at the end of the PR interval, that is the beginning of the Q wave to the end of the S wave. Normally the interval is 0.08 to 0.10 seconds. When the duration is longer, it is considered as a wide QRS complex. Whenever we see the ECG, we should always see the width of the QRS complex, whether it is a narrow or broad. We have to see the voltage of the complexes also, and at times we can make the spot diagnosis from the QRS complexes morphology. Normal QRS width is 70 to 100 millisecond, that is 0.7 to 0.10 second, but at times it can be 110 milliseconds in healthy subjects. The QRS width is useful in determining the origin of each QRS complexes. For example, whether it is sinus, atrial, junctional or ventricular. Narrow complexes, when the QRS complex width is less than 100 milliseconds, they are usually supraventricular in origin. Broad QRS complexes, when the QRS width is more than 100 milliseconds, may be either ventricular in origin or due to aberrant conduction of the supraventricular complexes, for example due to bundle branch block, hyperkalaemia or sodium channel blockade. Sinus rhythm with frequent ventricular ectopic beats in the petra of ventricular bigeminy. The narrow complexes beats are sinus in origin and the broad complexes are usually ventricular. In this ECG we can see it is showing both narrow and the broad QRS complexes. The narrow QRS complex morphology, as we said that narrow QRS complexes are usually supraventricular. They arise from the three places. They may come from sinoatrial node. Here we usually see a normal P wave. They may come from atria, then we will get abnormal P wave or flutter wave or fibrillatory wave, or at times when they originate from the AV node or junction, then either we don't get any P wave or we get abnormal P wave with PR interval less than 120 milliseconds. Here in the right sided ECG we can see narrow complex ECGs. First is the sinus rhythm ECG. Here we see each narrow complex is preceded by a normal P wave. In the middle ECG, here we can see the atrial flutter. The narrow QRS complexes are associated with regular flutter waves. And third one on the right side, which is at the bottom, here we see junctional tachycardia. The narrow QRS complexes with no visible P waves are seen. The broad QRS complex morphology. Broad or wide QRS complexes, when the QRS duration is more than 100 millisecond, we call it as abnormal. And the QRS duration, if it is more than 120 millisecond, is required for the diagnosis of bundle branch block or ventricular rhythm. The broad complexes may be ventricular in origin or due to aberrant conduction secondary to bundle branch block, or it may be seen in hyperkalaemia, poisoning with sodium channel blocking agents like tricyclic antidepressants drugs, pre-excitation syndrome like Wolff-Parkinson-White syndrome, ventricular pacing, hypothermia, intermittent aberrancy, that is rate related aberrancy. Differentiation between ventricular complexes and the aberrant conducted supraventricular complexes at times may be difficult. In general, the aberrant conduction of the sinus rhythm and the atrial rhythm, for example, tachycardia, flutter, fibrillation, they can usually be identified by the presence of preceding atrial activity, that is, P wave, flutter waves, or fibrillatory waves. However, the aberrantly conducted junctional AV nodal complexes may appear identical to the ventricular complexes as both produce the QRS without any preceding atrial activity. In the case of ectopic beats, the distinction is not really important as occasional ectopic beats do not usually require treatment. However, in cases of sustained tachyarrhythmias, the distinction between the ventricular tachycardia and the SVT with aberrancy becomes more important. This topic is covered in more details in elsewhere. Fortunately, many causes of broad QRS complexes can be identified by the pattern recognition. For example, right bundle branch blocks produces RSR- pattern in V1 lead and deep slurred S wave in the lateral leads. The left bundle branch block produces dominant S wave in V1 with broad notched R wave and absent Q waves in the lateral leads. Hyperkalaemia is associated with range of abnormalities including peaked T wave. Tricyclic poisoning is associated with sinus tachycardia and the tall R wave in AVR. Wolff-Parkinson-White syndrome is characterized by short PR interval and delta waves. Ventricular pacing will usually have a visible pacing spikes. Hypothermia is associated with bradycardia, long QT, Osborne waves, and shivering artifact. Coming to the high voltage QRS morphology, here we see increased QRS voltage, which is often taken to infer the presence of left ventricular hypertrophy. However, high left ventricular voltage may be normal finding in patients less than 40 to 45 years of age, particularly who are slim or athletic individual. There are multiple voltage criteria for left ventricular hypertrophy. Probably the most commonly used are the Sokolov-Lyain criteria, that is S wave depth in V1 and tallest R wave height in V5 or V6. If we calculate their sum, it should be more than 35 mm, and the voltage criteria must be accompanied by non-voltage criteria to be considered diagnostic of left ventricular hypertrophy. The low voltage QRS morphology. The QRS is said to be low voltage when the amplitude of the QRS complexes in the limb leads are less than 5 mm or when the amplitude of the QRS complexes in the precordial leads are less than 10 mm. Electrical alternance. This is when the QRS complexes they alternate in height. The most important causes is the massive pericardial effusion, in which the alternating QRS voltage is due to heart swinging back and forth within the large fluid-filled pericardium. The spot diagnosis can also be made by seeing the QRS complexes, and these cardiac diseases they produce distinctive QRS morphologies which are important and they should not be missed. For example, Brugada syndrome. Here we get partial right bundle branch block with ST elevation in V1 and V2. Wolff-Parkinson-White syndrome, we get delta waves. Tricyclic antidepressants poisoning produces the wide QRS with dominant R wave in AVR. William Osler has said, one of the first duties of the physician is to educate the masses, not to take the medicine. With this, I conclude my today's topic. Thank you. Keep learning.